Hi, Vaibhav.
Hi, Navya. Can you hear me?
Yeah, you are audible.
Okay. Okay.
Hi, Mahima. Hi, Aditi. Hello. Am I audible?
Yeah, you're audible to me.
Okay. Okay, then we'll start now. Um, so I'll start. So my voice is audible, right? Uh, Vaibhav. Hello.
Yeah.
Yes,
Yes.
yes, Navya. Okay. So good evening, everyone. So today's as every Thursday, it's our fellow talk. So we'll start today's talk with Weber's topic on WHO ANC recommendation. Okay, so shall we start, Weber?
Yes, sure.
So I'm
So I'll request you to share the screen. Yeah.
yeah,
Thank
I'm
you.
sharing. So is my screen visible?
Yes.
Okay, Weber, you can start.
Okay. Thank you. Thank you, FPHS and Navya, for this opportunity. So, hi everyone. A very good evening. I'll be talking a lot about in this session about the new WHO recommendations that have come up for antenatal care. And this time, the WHO has recommended not just provision of care, but providing antenatal care in the sense that a mother can experience positive pregnancy experience. So when we talk about positive pregnancy experience, there are a lot of components, and we'll go into the depth of what these components are in this session, in this presentation. Uh, can we go to the next slide, please? Right. So we all know ANC is very much critical. ANC is important, and ANC provides us, in simple terms, if I tell that it provides us a window of opportunity. A window of opportunity, when I say uh, an opportunity to reduce complications that may happen during the pregnancy or that may happen at the time of childbirth, right? It also provides that opportunity to reduce stillbirths, which is again a major burden, and perinatal deaths. A lot of cases, a lot of systematic review have happened where this, and it is also published in the recent guidelines, that it has shown an impact based on the randomized control trials that have happened, and WHO has published it in their recent guidelines, that it is a directly linked with the reducing the perinatal deaths when we provide a quality antenatal care. What are the components of quality antenatal care that we are going to discuss? But as a whole, this period of antenatal care, this duration, it provides us that opportunity where a woman can get an integrated care throughout her pregnancy duration. And these recommendations, if followed, which provide us evidence-based, guidelines, evidence-based actions, and provide us the way forward in terms of promoting the health, in terms of what messages to be given, what counseling to be prioritized, and how to prioritize those messages throughout uh, her different trimesters of pregnancy. So these are the guidelines which provide us that way forward. And hence, this ANC period is considered a very important, and is called window of opportunity, and is emphasized a lot in these new recommendations, so that the woman at the end, during the delivery, can provide, can experience a positive pregnancy experience. Next slide, please. Yeah. So before we jump on to what new has come up, what WHO is now recommending, let's talk about what is there, what is presently happening in India, and what Government of India currently recommends. Again, based on the previous WHO guidelines, which came up some time back. Currently, in Indian context, we are following 4 ANC visits. We are following FANK model, which was also proposed by WHO. And then, after a lot of discussions, after a lot of research, WHO has now upgraded their recommendations, have now updated their suggestions, and now are now suggesting that 4 visits are not enough. Uh, a woman need to have at least 8 contacts. So 8 is not a magic number. It has again come up after a lot of research, and beyond 8, there are no positive benefits that can be given as compared to the cost and the other implications it will have. So 8 is the number that WHO is recommending now. However, the previous recommendation suggests that 4 ANC needs to be given, 4 ANC visits needs to be given to a pregnant woman during the course of her pregnancy. We all are aware about this current guideline. So one visit during the first trimester, that is before the 12 weeks of pregnancy, then one visit in the second trimester. As per the GOI guidelines, it is somewhere between 14 weeks to 26 weeks of pregnancy, and then in the third trimester, which is the most critical one, uh, 2 ANC visits are recommended between 32 and 36 week, and then after 36 weeks till the time mother delivers. So these are the 4 visits that are currently in place. In addition to that, Government of India also suggests that a woman should also get at least one medical officer consultation during the course of her pregnancy. And as part of the recent and this new initiative by GOI, a very applaudable initiative, that is Suman initiative. You must have heard this Pradhan Mantri Surakshit Matrata Abhiyan. And as part of this, there are additional extended and additional visits that are also recommended, out of which one visit has to be from a specialist, that is OBGYN. So these are the current guidelines, but there is a catch here. As of these guidelines, these are mostly focused on the high risk pregnancy cases, high risk pregnant women. However, if we can go to the next slide, please. However, the recent recommendations by WHO, they are suggesting that irrespective of the high risk condition, high risk status of the pregnant woman, all the women should get at least 8 ANC contacts, and these are also again distributed across the trimester, just like the Frank model. These are also distributed across the 9 months of pregnancy, which we'll talk later. Why these recommendations? When we ask why, what is wrong with the current guidelines? So when we talk about the revised recommendations, these a lot of these recommendations talk around and discuss around the maintaining a physical and socio-cultural normality, right? So there is, as we all know, India is a diverse country and there are huge geographical disparities. And as we move from our urban setup to a rural setup, and even from one state to another, the scenario changes a lot, right? So I'll talk more on this in my next slides, but we are currently doing one research in one of the state of India, that is Assam, and the geography is so diverse, so different from when we move from one district to another, that we have to adapt according to that particular context, right? So this recommendation talk a lot about contextualizing the recommendations, contextualizing those set of services that women should get, and also maintaining that socio-cultural normality, because we have all strata of all socio-cultural and all socio-economic strata in our cohort. So we need to adapt according to that. Also, these new recommendations also talk a lot about maintaining a healthy pregnancy for mother and baby, because we need to focus definitely on the high risk cases and to prevent those mortalities, which government of India is also emphasizing a lot currently. But these recommendations also suggest the same, and also it talks a lot about quality of care. So it aims to provide that positive pregnancy experience which I mentioned earlier, as the woman transit from her pregnancy period to at the time of delivery, and at the time of the birth of the child. Next slide, please. Yeah. So when I talk about quality, quality is very subjective, but here it is very much defined in a way that quality care should be provided throughout the continuum. Suppose a pregnant woman is identified at one particular ANC session in one particular village as high risk case, and then what happens to that woman, how she is followed up, where she is referred, whether she went there or not, whether she, when she visited the higher facility, did she receive the required care she was supposed to receive or not? All of this. So basically, continuum of care is emphasized a lot, and this is how they have defined the quality in is one of the aspect of quality. There is a lot of emphasis on patient-centered care. So again, the same for each woman, the requirements, the need will be different, and uh, there is a lot of emphasis on defining those requirements and then providing that defined care to that particular woman. Uh, this aims to achieve this quality, providing this quality services aims to achieve reduced mortality, reduced morbidity, uh, more emphasis on providing respectful care, and it's not just one way kind of care delivery where the health system is supposed to provide care. It is also bi-directional, where women views and their perception and their requirements are also understood by the healthcare providers. And overall, when we talk about care delivery, we want to provide an optimized care delivery where an equal emphasis is given on all the uh, pregnant women, irrespective of their status, irrespective of their strata to which they belong. Next slide, please. So when I talk about these recommendations, there are three types of recommendations which WHO is suggesting. First are the set of services which are directly recommended, which if some country, because these are global guidelines, uh, and when we talk about Indian context, there will be some recommendations. Like if I give you an example, I'll talk in the next slide regarding nutritional counseling. So most of these counseling messages we are already doing. We are already covering it as part of our current ANC package. So these are directly implementable recommendations. Then there are recommendations which are with certain conditions, right? So there are recommendations which are only specific to a particular context. So suppose there is one particular village or one particular district in Northeast which is endemic for malaria. So providing those prophylactic malarial drugs and providing those malarial bed nets, insecticide treated bed nets to those particular region is recommended because it is very much context specific and is not recommended to all the other geographies where the malaria is not that much of an issue. So these are the recommendations with certain conditions which are specific to context, where more research is required and directly it is not suggested to be implemented. And then there are recommendations which are in practice currently in some of the countries, which WHO suggests that it should not be, it is not recommended. It has no additional benefit to pregnant women and can be discontinued. So these are the three types of recommendations which WHO has suggested. And now what all recommendations are there and what all categories of recommendation are there. So I'll briefly talk about the categories because it's a long guideline and we do not have that much amount of time, but I'll definitely want to just have a cursory glance over the categories of the recommendation. So basically there are five categories under which these recommendations have been categorized. Total there are some odd 49 recommendations which are divided into these five categories. First category belong to nutrition intervention. We are currently celebrating Poshan Ma and Poshan Abhiyan is going on, and WHO is also equally emphasizing a lot on nutritional aspect because nutrition has direct linkages to the morbidity and mortality in antenatal and perinatal period. So nutritional interventions, under nutrition interventions there are some 14 recommendations which you can go through. Then there are recommendations in terms of maternal and fetal assessment. So if I give you an example, it is recommended by WHO that a pregnant woman should get at least once the her abdominal examination or fetal heart rate checked at say for 24 weeks of pregnancy by a skilled healthcare provider. So these are the example of the maternal and fetal assessment related recommendations, and then there are again such 13 subcategories under this broad category of maternal and fetal assessment. Then there are recommendations regarding preventive measures, which I previously mentioned, like malaria. So it is only specific to that particular context of endemic regions. Then there are recommendations regarding counseling related to common physiological symptoms. So common physiological symptoms like in pregnancy, there are usual set of physiological symptoms that appear, and a pregnant woman should be counseled, should be adequately informed about these symptoms and these conditions uh, at the onset of the pregnancy itself. So, and the last is regarding health system interventions, where a lot of emphasis, it is again under research, and a lot of debate is around uh, task shifting, and then adding an additional cadre other than medical officers for the low resource setting and all. So you can go through in detail these as part of these broad recommendations. I have just briefly covered what all categories are discussed as part of these new guidelines. Next slide, please. Yeah. So this is what I was referring. I've just uh, symbolically, I've just copy pasted these snapshots of these recommendations, which I was mentioning earlier. So as nutrition interventions, there are recommendations in terms of dietary interventions, right? So and then there are recommendations in terms of improving and providing in services, and if not services, then providing that kind of environment so that the woman can share if she is experiencing any intimate partner violence. So these are the kind of recommendations which is covered in this broader guidelines. Next slide, please. Yeah. Then I mentioned about these three types of recommendations. So first is like directly implementable recommendations. Just for example, this is one example for TD vaccination, which is again uh, currently practiced in Indian settings and Indian guidelines. So there is no issue and there is no hurdle basically in implementing and in adopting these. So these are very low hanging fruits, we can say, which are already achievable, and WHO recommends it to be implemented as it is. Then next slide. Yeah. Then there are recommendations which I mentioned, like these are context specific, like IPV. So when we talk about IPV in Indian settings, there is no particular mechanism that exists. Even if as a part of this ongoing research we are doing, uh, even if we train healthcare provider, there is no established mechanism where the woman should be referred, on what aspects the woman should be counseled, what are the interventions that need to be uh, undertaken if a woman shares her personal story or personal experience when we talk about IPV. So these are the recommendations which require more research, which require more uh, brainstorming, and which require more guidance from the policy level, so that a mechanism can be established and then these can be recommended or implemented in the particular setting. Next slide. And then there are recommendations which are not suggested, which are if some country is following it, for example, multi-micro nutrient supplementation, or for example, B6 supplementation, or vitamin E or C supplementation, or vitamin D. So all these multi-micro nutrients or vitamins, or these multivitamins, if a pregnant woman is given these additional supplements during her pregnancy, these are found to have no additional benefit or no additional impact on her overall health. So WHO suggests as part of these new guidelines that these are not advisable and these can be removed or dropped from the current existing guidelines by the country. Next slide, please. Yeah. So I have talked a lot about what is there, but what are the key highlights? Because many of these things that we have mentioned here, like nutritional interventions, dietary interventions, right? Many of these are already there in our system. And many of these we are already following. So what is the key highlight? What are those key highlights that are new in this particular new guidelines? So first is next slide, please. So first is regarding increasing the number of contacts. So when we talk about, firstly, when we talk about these guidelines, and when we compare it with the previous model, FANC model, which Government of India is also using currently as part of its ANC services and ANC program, uh, it mostly talks about visiting 4 times during the course of the pregnancy. However, WHO is now suggesting we change this model and we ask women to come and get in touch with the healthcare provider 8 times. How these are distributed? So first contact will be in first trimester. There will be 2 contacts in second trimester. Then there will be 5 contacts in third trimester. I know it sounds a little ambitious, but it is very much achievable, because when we talk about antenatal period, and when we talk about uh, you know poor outcomes during the delivery, poor delivery outcomes, or poor perinatal outcomes, a lot of this is influenced because of the conditions that arise in the third trimester, which is considered a high risk period. So if we have more number of contacts, if the healthcare provider can be consulted or can be referred more number of times during this particular trimester, a lot of morbid conditions can be controlled at an early stage. And these are preventable conditions which can be turned from a high risk to a low risk condition, and we can get better outcomes if we have more number of contacts during this. Next slide, please. Yeah. If you have looked into this specifically, there are terms that are used in this. So this time, WHO has not used the term visit, but has now shifted to the term contact, right? So why this change? So when we talk about contact, WHO has again defined it and very explicitly, and is suggesting that when we talk about a quality antenatal care, we need to have a contact, and contact implies that it is not just one-way kind of a communication; it's a two-way communication where healthcare provider and pregnant women can exchange their views, can share the information with each other, and can provide a more person-centric care. So that's why they are using this word, replacing this word visit with the word contact, so that it can have a more the two of these provider and beneficiary can have a more close connection in terms of receiving care and providing care. Also, when we talk about contact, WHO suggests that this contact can be achieved. It is not particularly mentioned in the guidelines that it has to be given at the facility level, and these contacts could be done at the outreach setups as well. So, which is in our context, which are VHND sites where currently the session happens, and the woman gets the services there. So when we provide services, when the woman will get the services during in these outreach sessions, it will also be considered as a contact with the healthcare provider. However, when a community health worker like Asha in our case, and then there are contexts where Ashas are not there and Anganwadi workers are doing that kind of community outreach work. When that community health worker goes to a household door to door, that should not be considered as a contact, right? So uh, contact means a more skilled healthcare provider providing services, having a better connection with the beneficiary, and providing them all the necessary support, medical care, and information exchange is happening. So then we will define it as contact. Next slide, please. Yeah, and then there are recommendations, many of which are currently in practice in Indian setting, that at least one ultrasound is recommended before 24 weeks of pregnancy, and we all know that this helps in estimating the right gestational age, which sometime may not be correct when we do it with the conventional LMP method. So we need to have an ultrasound to estimate the gestational age. We also need to do this ultrasound as part of anomaly scan, where we get fetal anomalies detected at an early stage, and we also get to know that there are multiple pregnancies. If the woman had previous multiple experiences, then that can also be understand, that we can understand, and it also enhance better that what is presently going on, what are the high risk conditions, what are those conditions which need to be taken care of, all these greater details we get when we suggest an anomaly scan or a ultrasound scan at an early stages, that is after that is before 24 weeks. Next slide, please. Uh, Another aspect which we have already discussed in the previous slides is that WHO is now suggesting that pregnancy is more should be a aim should be a positive pregnancy experience. And when we talk about positive pregnancy experience, we are focusing on three important aspects. The care delivery should be respectful, it should be individualized, that is it should be person centered care. Okay, and the woman should get all the necessary medical care, timely support, all the exchange of information that is supposed to happen between a beneficiary and a care provider. Or when all of this is happening, then this will lead to, and with adequate number of contacts, which is 8 as suggested in the guidelines, then it will lead to a quality of care throughout the continuum, and then eventually it is going to give a positive pregnancy experience to the mother. Next slide, please. Right. So when we talk about effective implementation of these guidelines or overall ANC as part of health system, so we need to work on many aspects. Some of these are listed here. We need to work on the overall continuum. We need to work on the referral. When a woman is referred from an outreach or a sub center or a health and wellness center to a higher center, she should be able to navigate, she should be able to reach that particular department or wherever she is referred as per the condition she has been detected. So that continuum should be established. The care delivery should be integrated, uh, and it should not be, provided, the care should not be provided in silo and should be considered as a wholesome package and not just individual service. Improved communication with and support for women. So again, interpersonal skills, when we talk and when we especially deal with medical professionals, it's not that great because it is not very much emphasized also during the curriculum of the a particular medical professional. So interpersonal skills are very much important and very much emphasized in these guidelines. And when we establish that good interpersonal communication, it has been through research, it has been found that there is a better chances of diagnosing the high risk condition at an early stage if we could establish a good interpersonal communication between the healthcare provider and the beneficiary. uh, when we talk about all this care delivery, we definitely need availability of all the resources and all the supplies, because if we do not have, and we have all the required manpower and all the required human resource, skilled human resource, but we do not have supplies, nothing can be achieved. So definitely availability of services and establishing that supply chain mechanism is very much important, and it is not something very much far-fetched, because in other interventions, like when we talk about our universal immunization program, it is already, we are already doing it through EVN and all. So it is very much achievable. Empowered healthcare providers, so right, capacity building should be emphasized, and more staff should be allocated and optimized for the centers where there is no staff available. Next slide, please. Yeah, uh, you can skip to next slide. So this is one implementation research we are doing currently. It's a multi-country research. Next slide, please. It is going on currently in 4 countries, and in India, it is going on currently in 2 states of India, Assam and Tamil Nadu, which I previously mentioned. And it is being done in consultation with the central and state governments of both these states, and Japaigo is doing this implementation research on field, while WHO is also supporting it as a technical partner. Next slide, please. As part of this implementation research, we are trying to implement a contextualized care package, a contextualized ANC care package, which is prepared based on the WHO guidelines and contextualize based on the context specific state recommendations, and based on the tag uh, suggestions and all. These are contextualized. Whichever recommendations are not fit as per the state context have been removed. Whichever are suggested and not, like I mentioned, no context specific recommendations are also recommended in this package. And then there are some intervention strategies like capacity building, provision of resources, and community engagement and all those things which are currently being done so as to provide this ANC care package. And then we are also working a lot on improving this skills of the care providers. Next slide, please. Yeah, and this is, if you want to know more about this, this is the link to that protocol that we are working on and has been published. Next slide, please. And these are the links to the other important resources and guidelines that will give a greater idea of the new recommendations that WHO has suggested, and the previous work in other countries and in smaller geographies based on which these guidelines have come up. Yeah, thank you. I hope you like this, and I'll hand over to Navya now.
Yes, thank you, Vaibhav. So I would like to like conclude that this is like very comprehensive. You have mentioned every uh like everything in detail and in much simpler way. That is which I like the most. And rest I leave up to all the fellows if they want to add something or they want to ask something. So we can have an interactive session over this topic also, because I think there is a lot of work is going on sexual and reproductive health. So if anybody needs to add something.
Yeah,
Yeah,
and I'm
sure.
sure many of the fellows are also working in the same field, so I would like to know their uh, thoughts on this.
Yeah, you can share your experience, Dr. Zoha, please.
Yes. Okay. So first of all, Dr. Vaibhav, thank you so much. This is great value addition to the current work which I'm actually doing. I'm into RM and CH. So thank you for that. It was really very comprehensive, as Navya said. Okay, so I have a few like I'll share also, and I would like your opinion also. Like one of the recommendations that you mentioned was a 7-day antibiotic regime for all pregnant women. So, have they mentioned anything around, antimicrobial resistance? Because that is also one of the things for which the recommendation says that you do not use it until unless it is very necessary. So, have they mentioned anything around it, and how much feasible it is to apply it in the current context? Seeing that we are facing this challenge of antimicrobial resistance also coming up.
Yes, thank you, Dr. Zoa. Yes, definitely, it is a very pertinent question and a very pertinent point that antimicrobial resistance is a challenge, and that's why in this new guidelines, they have not recommended it, but have said that context-specific recommendation and more research, more rigorous research is required. When they say research, why it is mentioned? Because in Indian current guidelines, there is no provision to test for, say, a very common maternal infection, asymptomatic bacteriuria. And in this work that we are currently doing, we are providing that multi-urine dipsticks, and we are testing, doing this urine test at the point of care level at the VHND sites itself. And we are finding a lot of ASB positive cases where the leukocytes count is high and all those things. So currently it is not even tested, and we don't know. So it is, even when we talk about NCD, we remember we talk about the tip of the iceberg, but here even the iceberg is not even visible through our naked eyes. So we are just trying to build some evidences that this is also an issue. This also needs to be checked. we also need to identify what is the prevalence of ASB in our cohort of pregnant women in India. And then based on that, whatever those endemic areas are, we can provide preventive antibiotics in those, of course, based on more rigorous testing like culture report and all. But we can think about those aspects, but it is not directly recommended. It is a context specific recommendation.
Yeah, thank you, Vaibhav, so much for that shedding the light on that point. My second question is around there is a wonderful recommendation regarding this intimate partner violence. So, has any country been named in this context that is currently applying this? I mean, they are using this recommendation, or is it still an open recommendation for all?
Yeah, I could not find any particular
Okay.
mention of a country where this was
Hmm.
suggested, but again, it is also a context specific and more based on the various parameters and various, system level preparedness. Countries can adapt these recommendations and these IPV related mechanism, because intimate partner violence is again one issue which is there in our Indian community, and we are already
Hmm.
as part of NFHS, we are already measuring it. We already know this prevalence is there
Hmm.
uh, of domestic violence, but still there is no established mechanism, especially when it comes to a critical period like ANC. So yeah, it is
Yes.
again suggested that if such
Okay, so
mechanism can be developed and explored. Yeah.
all I wanted to ask was that there is no current country which is as such seen in this guideline which is reported to be using it. Okay.
Um, I'm sorry, not that I'm aware of, but
Okay.
I
Okay.
can
Okay.
definitely look into it and we can look into it.
Yes.
But
Yes.
I'm
Yes.
not
Yes.
aware of that.
That is something. I mean, I was thinking of the.
Right, right. No, it's a very
Okay, so you
pertinent
got it.
question.
What I was thinking. Okay, that's
Yeah,
good.
yeah, yeah.
Okay.
Yeah, I think so.
Yeah. Yeah. Yes, Miss Dr. Rupshi. I'll ask
Yeah,
after.
thank you, Zoha, for this wonderful question. I would like to just give you in the perspective of our NHSRC, Indian Ministry of Health and Family Welfare, has got portals related to Saksham and also Muskan, where we as panelists, we have been enrolled for seeing how this pregnancy and also the child care, how are we giving the care component, the quality aspects. So entire India, we have so many people who have been in trained. We have been also given the portal, and also we are able to see the care component in each hospitals, the pregnancy experience. The Muskan is the child. How exactly the baby is taken, because it's a part and parcel, both mother
Yeah, the
and child.
quality at Muskan. Yeah.
Yeah, and we
Yes.
try to see how the care is being given using parameters, and it is all software based. And we do see how these parameters are being involved and how is the effectiveness of it is being measured. I just thought I would add this.
Okay, thank you so much, Dr. Rupshri. Vaibhav, my third question is when the regime of that 8 ANC visits has been given by WHO, uh, like I was seeing it, and recently there was a uh, big, I think, conference also held by JPIGO in Delhi itself, where these recommendations, along with the, I think, various members from NHSRC, was held. There also, I think, Tamil Nadu was one of the countries that was in current time implementing this 8 ANC visits, if I'm not wrong. I mean, somewhere down the south they are using this 8 ANC model, and also probably in Gujarat. My question is for places like UP and all this northern belt, uh, do you do you see that increasing the number of visits would make really a difference when the quality in the 4 ANC itself is very much compromised? I mean, what's your point on that?
Yeah, you're very much right. So currently, I think in Gujarat, you're right. JPIGO held this event, national consultation on ANC. in New Delhi and Gujarat, when one of the state official from Gujarat, he presented, he mentioned that they have already implemented this. But other than that, I could not find any other state who have this rolled out recommendations. In Tamil Nadu and Assam, we are trying to develop evidences, generate evidences around the benefit and the feasibility, because this is an implementation research. So it talks about all the 5 domains of implementation research, and it also covers about the feasibility and the costing aspect. What will be the additional cost implication on the beneficiary, also on the health system, not just beneficiary, also on the health system, because the healthcare providers also need to provide their additional time to these additional contacts. So yes, definitely it's not a easy task. It's definitely a very challenging task, but we are trying to generate evidences. What are those strategies? What could be those mechanisms through which there could be some slight tweaking can be done in the existing system, because our existing system is I can say one of the best when it comes to other countries, other LMICs, because we are providing services at the point where which is very close to the community, and that is one of the very critical aspect, that you have to provide services as close as to community, so as to not give an additional burden to the beneficiaries or to the pregnant woman, and to when we talk about those 3 delay models and all. So in current scenario, it is challenging, it is difficult, but based on this research that is going on, we'll be hopefully able to come up with some mechanism from the state and from the beneficiaries and from the community that will help us in implementing it throughout the country.
Yeah, and just to add one more thing is, I just wanted to mention in relation to the official website of Department of Medical Health and Family Welfare, Government of Uttarakhand. They have an official website where entire district female hospital and female welfare, and in relation to pregnancy and your antenatal care, the entire portal is dedicated, and the every hospital, whether it is a base hospital or a referral hospital or even first referral unit, and the district female hospital data is being extracted, and they are able to bring about a lot of changes, especially the state of Uttarakhand, and this is being done from at the government level and at the district level and the state level. So I just thought that would be an add-on to your talk.
Ma'am, is that some dashboard? Is it some kind of, what's the name of the portal?
You can just Google ASHA, ASHA, and it is their official website of Department of Medical Health and Family Welfare, Government of Uttarakhand. And the entire portal, from the point where the district female hospital data is being uploaded, and you can have a look at it. And even at the primary healthcare community health center, CHC, PHC also, you can get the information.
Okay, that is very good. Thank you, Weber, for all the insights. I mean, this is really very good discussion. Thank you so much.
And thank you, Dr. Dhruva and Dr. Rupashri, for your insights as well. Thank you.
Yeah, so Dr. Rupashri and Dr. Zuha, great question. Like, we really enjoyed the discussion. So moving on to Dr. Weber. So we are planning to have his talk tomorrow. Okay, so we'll wrap up here only. So Weber, it is Weber. Abhinav, it is okay with you, right?
Yes, Navya, sure. I'll be available tomorrow.
Okay, thank you so much. So we'll join tomorrow again. Okay. So thank you everyone for joining again, and thank you, Weber, for this talk. We'll discuss further. So for tomorrow, I guess we have topic multi-morbidity, right? So
yes.
We'll see. Okay. Bye. Thank you so much.
Thank you. Bye. Thank you.
Yeah, thank you all.